Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And the for the today's webinar, we have a very important topic, that is the inpatient diabetic, managing blood sugar during surgery and hospitalization. For this topic, we have very eminent speaker, none other than Dr. Anil Bhoraskar sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, consultant diabetologist at SL Raheja Hospital, Mumbai, and more than 32 years of experience. Dr. Bhoraskar has many papers and publication to his name in national and international journals. So, to know more about this topic, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thank you very much. Friends, this is a very important topic and I'll be very brief. So I'll give about few minutes for questions and answer. Am I audible to the audience? No problem? Okay. Now, what we're
You
going
are.
to discuss today is the role of insulin in hyperglycemia, particularly when you are talking about hospital setting. And that is the reason why there are so many diabetologists attached to all big hospitals, which are specialized centers for surgery. Like I'm attached to Raj Hospital, where all kinds of supramajor surgeries take place. You name the surgery in the world, we do it. Then I'm attached to Asian Heart Institute, where the number one surgery in heart in the country or even this part of Asia is being done for CABG and multiple valvular disease. And for that, I'm invited to take care of my patients who have diabetes. And multiple references from other centers come to us because we have a state-of-the-art heart center as well as diabetes management. Because intraoperative management of a post-CABG patient is very vital, and the blood sugar is targeted at a level of 140 to 180. Such a strict criteria maintained for a better post-operative results. And we have an excellent results from Asian Heart Institute. And then third place where I'm called is a Kambala Hill Cancer Hospital, where all kinds of supramajor surgery like Whipples, like jejunostomy, lobectomy, pneumonectomy, and multiple cancer-related surgeries, where a meticulous control of sugar is absolutely mandatory for better post-operative results and better healing of such a massive incisions. So that is the reason why management of diabetes becomes crucial in hospitalized patient, particularly for surgery. So managing hyperglycemia in hospital setting, we have anti-hyperglycemic therapy. Insulin is given as a preference. Oral anti-diabetic drugs are discouraged prior to surgery. Not that we don't give them completely. Some of the patients, in spite of insulin, may need crossover of oral drugs. But generally, what preferred is insulin because insulin is easy to give because it can be easily given intravenously. The dosage titration can be in mini units, 1 unit per hour, zero point 0.5 unit per hour. This kind of drips can set in. And IV insulin is preferred particularly in the first 48 hours after any supramajor surgery. Subcutaneous insulin is given to the people who are stepped down from ICU to wards or a second grade ICU or step down ICU, where IV along with subcutaneous is given, but subcutaneous is normally given at the time of discharge. Now, absolute or relative insulin deficiency and increased counter-regulatory hormone is a feature of any surgery. It is the counter-regulatory hormones which are anti-insulin hormones, catecholamines, and they cause a lot of disruption. Particularly, it causes breakdown of adipose tissue, causing increased lipolysis, release of free fatty acids to the liver, increase the glucose output by glycogenolysis. The amino acid lactates come from protein breakdown from muscles and glucose utilization is reduced, and all features ultimately result into hyperglycemia. So hyperglycemia is a consequence of so many processes which take place largely because of the stress hormones, surgical stress, or a catecholamine release, or so many other drugs which are given, and therefore the hyperglycemia has a lot of effects on the tissues as well as circulatory system. It has got issues on electrolytes. It can cause volume depletion by dehydration, hypoperfusion, loss of electrolytes, acid-base disturbance, and the tissue effects of reduced nitric oxide, superoxide generation, free radicals, oxidative stress, endothelial dysfunction. It causes platelet activation, immune dysregulation, and mitochondrial injury. All of this, which is unchecked, can lead to sepsis, multiple organ failure, and some cases death. So you'll realize it's a cascade of events which occur during surgery, which are so many factors which are responsible, which needs to be controlled. And the key thing to control in our hand, the one which can monitor easily, is a glucose levels. Glucose monitoring is a crucial during intra and post-operative care. Now, what are the guidelines of management of glucose levels in ICU? There are many associations which give different guidelines. Ultimately, we follow our own guidelines. American Diabetic Association, Canadian Diabetes Association, RSSDI. RSSDI is a standard organization in our country. Society for Critical Care Medicine, American College of Physicians, Surviving Sepsis Campaigns, American Association of Clinical Endocrinologists. Now, this is all ICU patients, and treatment threshold is kept at anything less than 180. It's little liberal. There are some people expect 140 to 180, stringent, never above 180 at any given time. And the ideal thing to be less than 160. So these are the various guidelines. But by and large, the whole world is agreeable on the figure of 140 to 180. Now, glycemic targets for critically ill patients, starting threshold no higher than 180. Once IV insulin started, the glucose levels should be maintained between 140 to 180. Lower glucose targets 110 to 140 may be appropriate to selected very critically ill patients, young people with a tremendous comorbidity, with a sepsis, with the people, particularly people who undergo amputations with a septic wound. We have to be very strict. People with altered renal functions, people with high azotemia, people with electrolyte imbalance, we have to be very stringent, less than 140. Not recommended anything less than 110. Blood sugar going less than 110 also not accepted. Acceptable between 110 to 140. Recommended most of the patients and most of the center 140 to 180, and not at all recommended anything going 180. 8822 glycemic targets recommendations. Insulin therapy should be initiated for treatment of persistent hyperglycemia starting at threshold of more than 180 and checked on 2 consecutive occasions. Once insulin therapy is started, a target glucose range of 140 to 180 is recommended for majority of critically ill and non-critical patients. More stringent goals such as 110 to 140 may be appropriate for selected patients. Basal insulin or basal plus bolus correction insulin regimes is preferred treatment for non-critically ill hospitalized patient. That means a single basal shot and short-acting multiple doses of a short-acting insulin either given subcutaneously or intravenously. Now there are better analogs available which can be given subcutaneously. Don't need an IV access because it can act as fast as IV insulin and the life is short. There are ultra short acting analogs like FIASP which can be given immediately. Advantage, it can be given after lunch also. It can be given after food. An insulin regime with basal and prandial correction component is preferred treatment for non-critically ill hospitalized patient with a good nutritional intake. If the patient is eating well, you can start one basal shot in the morning and then small 3, 4, 5 doses of a short-acting analogs. Use only a sliding scale regime in patients hospitalized setting in strongly discouraged. We do not use sliding scale technique at all. Sliding scaling, bury it down. We don't use it because sliding scale is telling you the sugar levels, what has happened in the past. It is building a castle of a glycemic base which is old. It acts on the blood sugar which are telling you what happened in the fasting state. Based on that, you calculate dose. No, you are actually calculating the dose of insulin, what the patient is going to eat. You're going to give him his glycemic load and you're going to calculate his insulin dose according to what he's going to eat, what is his activity, what is the other comorbid condition. So sliding scale is buried. Nobody uses that technique anymore. Basal bolus versus sliding scale. Sliding scale is very inferior. If you see, the days of therapy, glycemic control rapidly improved after switching to basal bolus. If you see the first slide, changes of the blood glucose concentration in patient treated with basal bolus regime, where everything is based on the previous blood sugar. The scales are variable. It's a glycemic variability which is very dangerous, not the high sugar. Insulin regime for managing hyperglycemia in non-critical setting. Sliding scale is outdated. What we do is we do not want this roller coaster effect of insulin sliding scale. Up, down, up, down, up, down. Morning sugar 100, post lunch 300, after dinner 75, midnight 25, severe hypoglycemic crisis at the midnight. All these things we don't want. We want a steady state of insulin based on what the patient's action profile, activity profile, and the food intake. So, sliding scale is a non-physiological with a retrospective reaction to the blood glucose level, poorer glycemic control and increased risk of hypo, promotes glucose roller coaster and cannot predict insulin dosage requirement. It is not individualized and reactive approach practice, which is not acceptable. Basal bolus is of course superior efficacy compared to subcutaneous insulin. Physiological way of glycemic control. ADA recommends use of basal bolus regime in patient setting. Addresses three important components. One is a basal fasting state insulin requirements. Bolus is the meal time insulin requirement. And correctional, if in spite of giving up pre-lunch sugar, a pre-lunch insulin dose, you have calculated that the patient will need around 20 units. You have given him a short-acting insulin, does not act as per your expectation, and a postprandial blood sugar is 250, then you give a small dose of a Phe-asp. Can be given correctional doses after lunch. That's one advantage. Implementing basal bolus therapy to manage patients with hyperglycemia in non-critically ill patients will improve glycemic control. Dosing of basal bolus in a non-critical care steps. Calculate the total daily dose. Supposing the patient for previous 2 days is required about 80-90 units of insulin whole day. He needs around 80 units. You use 80% of the total dose if switching from IV to basal bolus. If the IV dose he required in 24 hours, in the flow chart, you have calculated that total day he needed 100 units. You give 80% for basal bolus. Divide equally between basal 50 and bolus 50 in multiple shots. Say he needs that 100 units, 50 units basal, 50% divided small shots. Bolus insulin divided equally between 3 major meals. If you're taking breakfast, lunch and dinner. Major blood glucose 4 times a day, 3 pre-meals and 1 at bedtime. That's how it measures insulin sensitivity. Based on blood glucose measurement, the insulin sensitivity add a correctional insulin to bolus insulin. Based on fasting, titrate the basal insulin. Now, this is what we make some changes in obese patients slightly more, in renal and a lean body mass patient with a sarcopenic structure, you reduce the amount of insulin. Standard insulin is zero point 0.4 unit to zero point 0.5 unit per kg body weight, ideal body weight. Obese people need slightly more, and lean and with a renal compromise, they need zero point 0.3 to zero point 0.4 units. Correctional bolus, blood glucose minus 100. CB is the correction factor of a regular rapid acting insulin. CF is correction factor, and a basal dose is regular insulin calculated. This is a simple formula. IV insulin protocol in critical care. IV route for administration of surpasses subcutaneous route with the respect of rapidity of onset of effect in control. IV insulin is the best. You know why? If the IV insulin, you find that it has produced hypo, you can suddenly stop the drip. Once the IV is stopped, the half-life of intravenously given insulin is about 4 to 10 minutes. It will not have a sustained action as a subcutaneous. While you give subcutaneous, it will keep on releasing in the system over a period of half an hour to 4 hours. So IV sure, when you stop it, the action is over. IV insulin protocol, several published insulin infusion protocols safe and effective with the low rates of hypo. Example, the one which we have followed, Portland protocol, Lawin protocol, Yale protocol, Cup algorithm, Nance protocol, RBH algorithms. The exact protocol is probably less important. What protocol we use in our setting is our own protocols. I am not that big to say Boraska protocol, but it is Raj Hospital protocol, Asian Heart protocol, Kambala Hill protocol. Preparation of insulin infusion in ICU. 50 units of short-acting insulin dissolved in 50 ml of normal saline in 50 ml of disposable syringe. Intravenous infusion with electronic pump, self-guided at a steady state. You don't have to push it. It is automatically battery driven. And to maintain the blood glucose between 140 to 180. Control methodology, blood glucose to be controlled gradually in case of severe hyperglycemia by titrating the dose intravenous insulin. Prerequisite initial 15 to 20 ml of solution should be flushed through the plastic tubing to saturate the insulin binding sites of tubing. Please remember the insulin tubing, in spite of taking most advanced celestic kind of tubes also, the insulin gets stuck inside the walls of this tubing. And that is what actually delivery to the insulin to the patient is slightly reduced because of some amount of insulin. But that happens in only first drip. Subsequently, that drip continues. It doesn't take all the time. So first 10 to 15 units are probably, you have to increase slightly more thinking about this. The targets, the dose should be adjusted as per the levels of blood glucose. Monitoring done either by capillary or monitor sodium potassium level. Most important, hyperglycemia be brought down rapidly can cause severe hypokalemia. So potassium monitoring is very important because hypokalemia or hyperkalemia can create more electrolyte imbalance and sudden death. So respect potassium as much as you respect sugar. Check regularly for blockage and disconnection, infusion pump malfunctioning. This can happen. The function of the battery operated gadget can suddenly stop at night. You have gone to sleep, your nurse on duty is on sleep, and patient is in deep sleep. Starting IV insulin infusion, give a priming dose of short-acting 0.1 unit kg body weight, blood glucose more than 300. Infusion initiation, initial rate of infusion with the current blood glucose minus divided by 100. Patient blood glucose is 200. Then initial infusion rate is 100, 200 by 100 is 2 unit per hour. Simple. Since each ml of insulin drip consists of one unit of insulin, the rate will be 2 ml per hour. Adjusting insulin infusion rate adjustment, monitor capillary blood glucose, consider current blood glucose, previous blood glucose, current rate of insulin infusion, rate of change or a lack of change. These are all available in various algorithm charts which are put in the ICCU center counter. Blood glucose prior to CBG infusion dose, blood glucose drop 30% from prior CBG infusion dose to be increased. Blood glucose drop more than 30 from prior BG, same infusion dose till blood glucose is 180. Keep a 180 as a target. Keep on checking blood glucose. It drops 30, 30, 30 every time. You have to increase the rate of insulin till the blood glucose drops to 180. This is an ordeal. This needs a training. Adjusting the insulin infusion rate, very simple. Blood glucose, blood glucose from prior blood glucose drop less than 30, blood glucose drop more than 30, rate is changed from 241, 3 unit per hour, rate no change if the blood glucose drop is more than 30. Now this is a very long chart. This can be copied by you and you can keep it in your ICCU. Recent training use of insulin in hospitalized patients. Important metrics of basal insulin to be clarified in inpatient care. Onset of action, the Digludac, which is a new drug. Clargin, which has a long-acting action. And it is to be given subcutaneous. Now, hospital trials are multiple. Digludac efficacy and safety with each titration. This shows that it has worked very well. IDEO study also shows lower hyperglycemia with Digludac. Digludac has come out as a good drug for a subcutaneous injection, as effective probably or more effective than Clargin. Now, Simioy et al. Low hypoglycemia with Digludac. In summary, Digludac is effective and safe hospitalized patient. Digludac can be safely titrated daily. Evidence has shown that insulin Digludac cohort attained a mean blood glucose which was within the ADA recommendation of 140 to 180. And it's a safe drug. But please remember, this drug we are talking about when the patient is being discharged, not when the patient is actively given. Active insulin is still intravenous Novorapid or Actrapid, which is now by sort of passed away. But a wonder drug has come as a FIASP, rapid acting insulin analog. Advantage of the FIASP is that it can be given post-op, post-lunch, and any time when you are slightly worried that the blood sugars are fluctuating, you can give short, frequent doses of that subcutaneously given as effective as intravenous insulin. And so there are luckily multiple injections we are available for intravenous use in ICCU as well as subcutaneous use in ICCU and step-down care. And on a discharge summary, we can educate the patient for various pains, how they take self-injection, how most importantly monitoring. Monitoring and insulin therapy is like a maifal, like a Sangeet, Gayak and Tabalji. Without one, you cannot enjoy. So, monitoring is as important as intravenous insulin as well as subcutaneous insulin. Thank you very much for your patient hearing. If there are any questions, I would be very happy to answer. Yeah. Yeah.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice too, sir. We have received some questions, sir. With all your permission, shall we take these questions one by one?
Please, the person should know, tell me the name and then ask the question.
Yeah, sure. The first question is from Dr. Subramaniam. He's asking what is the recommended approach to restarting oral anti-hyperglycemic medication prohibitivity?
The recommended approach is individualized. Now, what I do, that if the patient is under my care in Asian Heart Institute for 7 days, or normally 7 days, the patient is discharged and he comes for stitches removal after 15 days. So during the time when he is discharged, I try to divide his entire insulin regime into one basal and two or three boluses, and I substantiate drugs to improve the insulin resistance. And one of the drugs that we use, if the patient's creatinine levels are normal, metformin. The new generation drugs like SGLT2 inhibitors we avoid for some time, although it's a very good drug for bringing down the blood sugar, but not I give it for at least 8 to 10 days after surgery, largely because it can produce ketosis and cause dehydration because of loss of fluids. And gradually, the oral hypoglycemic agents have to be considered considering the patient's appetite has gone down. He's got many other drugs going on simultaneously, like aspirin, copicrel, antibiotic. His appetite is poor, and as it is not eating. So drugs which can act through this mechanism, which cause GI upsets, like all the new generation GLP-1 agonist, GIP-1 agonist, all these new drugs which are very fanciful and very nice, which we avoid. The only drug that I recommend is sulfonylurea if the patient's creatinine is all right, and a short-acting sulfonylurea once a day, considering that he does not go into late hypoglycemic episode at night because he is not managed because dinner may be very small or he may have vomiting at night. So all those things have to be highly individualized, and the patient and his relatives have to be in constant contact with us for at least 15 days. Once he comes for stitches and the stitches are clean and everything is fine, and many times I stop the insulin also, and I give them only oral drug what he was formerly well controlled with. So that is my approach.
Thank you so much, sir, for sharing your expertise on this question. Moving forward, we have another question, sir. How should eternal and perinatal nutrition impact diabetes management in hospitalized patients, sir?
Internal administration of food is not very difficult, but parental nutrition is a big problem, particularly in my patients in cancer hospital, where they undergo a total gastrectomy and they have what is known as jejunal feeding. Now, gastrointestinal tract is a very important aspect of nutrition. You cannot underline the importance of GI tract. You cannot give parenteral nutrition as effective as enteral nutrition because absorption of so many factors cannot be mimicked. Even if you give intravenous lipids, intravenous proteins, intravenous amino acids, the half life is very short, and therefore ultimately jejunostomies are done in people who have undergone Bepals and major gastrectomies and things like this or intestinal surgery. This jejunal feeding is a nutritional PhD. People have done PhDs on only jejunal entering feedings, and the jejunal feeds are created, marketed very effectively by many companies. But we have done our own cocktail kitchen, which consists of dal, pani, rice, vegetables, essence, minerals, nariyal ka pani mixed together with all the important vital nutrients, proteins, fats, minerals, carbohydrate, antioxidants, and these rations are given, and the nurses are trained to do a jejunostomy feeding through a tube with a big syringe. and it works quite well. And the most important, with the jejunal feeding, a patient must get a satisfied bowel. If he passes normal stool, provided he is not undergone post-op cancer colon as well. Now that's a big problem. The colostomy bag and geniostomy bag, it's a big problem, feeding. But enteral feeding through Riles tube is easier that way because stomach is an amazing organ. Through Riles tube, you can feed a person for years together. But when the stomach is removed, and remember the gallbladder, the bile, the intestinal juices, all have to be mixed. They have tons of vital elements which you cannot replace. So we are very happy if the patient is on RT, then patient is on JT. JT feeding is difficult. It's a time and experience. I have started giving albumin, white of egg, dissolved in milk through tubes. Some people have a problem of digestion of that protein, high protein, but small dose you can give. There are commercially available preparations also quite effective, but it's an art. You have to consider that all patient develop some other nutritional deficiencies which you have to correct injectable. You may have to give poly injections containing vitamins, B complex, vitamin D particularly, because vitamin D is a oil soluble vitamin D, and vitamin D deficiency can come suddenly and can have variety of, because after all vitamin D is a pro hormone. Remember one thing, vitamin D deficiency can create a lot of resistance problems because cause a lot of immunological problems. It can invite infections. So nutrition is a very important role in a post-surgical patient.
Thank you so much, sir, for sharing your experience on this question, sir. I hope that all the audience are getting their queries solved from your end, sir. One last question I can see from Dr. Sandeep Jaiswal. He's asking what is the preferred insulin regime during surgery, continuous infusion versus basal bolus therapy, sir. Please.
Continuous infusion therapy for first few days, followed by basal bolus after the patient starts eating. If the patient starts eating early, you start basal bolus therapy. As soon as he starts eating little normal food, basal bolus is preferred. Otherwise, till such time his GI intake is not adequate or optimum, then we give only intravenous insulin therapy.
Thank you so much, sir. One feedback from Dr. Subramaniam. Very well presented. Thanks for answering my question.
Thank you.
Like I hope, sir, I can't see any further questions from the participants, sir. I hope you have done justice to this topic, sir. As there is no
Sure.
more questions, sir, with all your permission, shall we conclude this session for today?
Yes, please. Thank you. Thank you.
Welcome, sir, and we would like to see you in future also with different topics, sir. Till then, take
Pleasure,
care of
pleasure,
yourself.
pleasure. My pleasure.
Have a great day. Take care, sir. Thank you.
Thank you. Thank you.